Dear friends, today we will see an algorithmic approach to the diagnosis of hematemesis. First, we will start with a case history. A 44-year-old white female is brought in the middle of the night to the emergency room with a history of vomiting bright red blood. Following the algorithm, you look for a history of fever and chills and find none. Her temperature is 97.8 degree Fahrenheit. There is no history of drug or alcohol ingestion, but she ate out the evening prior to the admission and the food did not agree with her. There is no abdominal pain. On further questioning, you find out that there was no blood in the initial episodes of vomiting. You suspect Mallory-Weiss syndrome and esophagoscopy confirms your suspicion. So, whenever a case with a hematemesis presents, you have to ask the following questions. Is there any fever? The presence of fever should suggest scarlet fever, measles, malaria, leptospirosis, yellow fever, and other acute and chronic infectious diseases. Next question. Is there a history of ingestion of poison, drugs, or alcohol? Poison, many drugs, and alcohol may cause acute gastritis, gastric ulcer, and erosive esophagitis. Third, is there any associated abdominal pain? Abdominal pain associated with the hematemesis suggests the possibility of gastric or duodenal ulcer, a hiatal hernia, and esophagitis or carcinoma of the stomach. Of course, any of these conditions may occur without abdominal pain. The fourth question is, was the hematemesis preceded by blood-free vomitus? If in the initial stages of vomiting, the vomiting was blood-free, one should consider Mallory-Weiss syndrome, which is a tear of the distal esophagus due to severe vomiting. The fifth question is there hepatomegaly or splenomegaly? Hepatomegaly would suggest cirrhosis of the liver, whereas a portal vein thrombosis may occur without hepatomegaly, but almost certainly is associated with the splenomegaly. Splenomegaly should suggest Banti syndrome with depression of platelets, leukocytes, and anemia. Splenomegaly also suggests other blood dyscrasias. Then, is there a positive tourniquet test or IV skin bleeding time? These tests may indicate thrombocytopenia and other blood dyscrasias. If these tests are negative and there is no hepatomegaly, splenomegaly, or abdominal pain, one should consider hereditary hemorrhagic telangiectasia, an aortic aneurysm, and pseudoxanthoma elasticum. So, based on your suspicions, the diagnostic workup will be hematemesis, no matter how small, is a clear indication for immediate consultation with a gastroenterologist, and esophagoscopy, gastroscopy, and duodenoscopy need to be done. To delay this, while ordering an upper GA series and other diagnostic tests may place the patient in serious jeopardy. The clinician would be prudent to order a CBC and coagulation profile, type and cross match of several units of blood while waiting for the gastroenterologist to see the patient. If endoscopy fails to locate the site of bleeding, order a CT scan of abdomen or better a CT angiography of the abdomen. Catheter angiography is often employed. A technetium 99M bleeding scan may be ordered to detect suspected bleeding but will not often locate the exact site of bleeding. Video capsule endoscopy can visualize the entire small intestine for bleeding sites. Liver function tests should be ordered to rule out the cirrhosis in all the cases. So this is the algorithmic approach to a patient presenting with hematemesis. All the best.